When beginning your medical assessment, we always want to start with standard precautions. Is the scene safe? We can use some of our dispatch notes to determine some of our scene size up, such as number of patients or whether the call is a nature of illness or a mechanism of injury. A nature of illness call is a medical call, and a mechanism of injury call is a trauma call. We will also want to call ALS because chest pain can be life-threatening, and we're going to want to defer SMR at this time, but we do want to assess that when we arrive on scene. Next, we're going to move into our general impression. Here, all you have to really do is ask your proctor, what's my general impression? Also, ask them, are there any immediate life threats at this time? Then you can move on to getting your patient's level of consciousness. To do this, we use the AVPU scale. So we can determine if our patient's oriented to person, place, and time with a couple questions. To determine if they're oriented to person, ask them what their name is. To determine if they're oriented to place, ask them where they are. And to determine if they're oriented to time, ask them what year it is. Next, you can move on to your chief complaint. Here you just want to ask your patient, why did you call us out here today? If your patient uses the word pain to describe their chief complaint, you will want to use the word pain. If they say discomfort, use the word discomfort. Now you can move on to your ABCs, or your airway, breathing, and circulation. First, we're going to begin with A, or airway. All you have to do here is say that your patient's airway is patent because they're able to talk to you in full and complete sentences. Then you can move on to B, or breathing. Here we want to get our patient's respiratory rate and tidal volume, as well as an SpO2 reading. The SpO2 reading is low, so you will want to give a nasal cannula because this is a chest pain patient. The reason why we give nasal cannulas to chest pain patients is because we don't want to over-oxygenate our chest pain patients. Then we can also move on to circulation, or C. There are a couple steps in circulation, starting with major bleeding. We'll see if there's any major bleeding present. Then we can move on to getting our patient's pulse. We'll assess at the radial site. And then we want to get our skin color, temperature, condition, and capillary refill. In order to get your skin color, you can have your patient pull down their eyelids like so. To get their condition and temperature, place the back of your hand on your patient's forehead. And to get a capillary refill, just squeeze the top of their finger. Next, we're going to move on to our transport decision and determining if our patient is a priority or not. Anything wrong in the ABCs, your patient is a priority and you need to expedite transport. So in this case, my patient is a priority transport because there's an alteration in their ABCs. Their SpO2 is low, so I am going to expedite transport. Now that we're in the back of the ambulance, I'm going to start my history taking, starting with OPQRST. So we're going to start with O, or onset. Here we're going to ask our patient if their chief complaint came on sudden or gradual. Sudden meaning maybe they were watching TV and that pain or discomfort hit them like that instantly or out of the blue. Gradual meaning maybe they were watching TV and that pain or discomfort was there, but then it slowly started getting worse and worse and worse, and that led to them calling us. You'd also want to ask if that chief complaint is constant or intermittent. Constant meaning that pain or discomfort stays there, it does not go away. Intermittent meaning that pain or discomfort doesn't stay there, it does come and go, or maybe it comes in waves. Next, we'll move on to P, or provocation. Here you're going to want to ask your patient, is there anything that you can do that makes your pain or discomfort better or worse? Then you can move on to Q, quality. Here you'll want your patient to kind of describe their discomfort or their pain to you. You can give them some options, maybe like heaviness, crushing, dull, sharp. And then you can move on to R, or radiation. So for chest pain, R is radiation. For any other medical assessment, R is reoccurrence, because radiation is not really relevant. The reason why radiation is relevant in chest pain is because the heart doesn't have any nerves, so the brain has to make other things hurt. Next, you'll move on to S, severity. Here, all you have to do is ask your patient on a scale from 1 to 10, 1 being no pain at all, 10 being the worst pain you've ever experienced, how would you rate your pain or discomfort? Then you can move on to T and ask your patient, how long has this pain or discomfort been going on? You'll also want to ask some clarifying questions. These are additional symptoms that go along with the patient's chief complaint. So for chest pain, things like shortness of breath, dizziness, lightheadedness, nausea, you can ask those. You really only have to ask 1 or 2. Then you can move on to ample, starting with A, or allergies. Here you'll just want to ask your patient, do you have any allergies? Then you can move on to medications, or M. Ask your patient if they're prescribed any medications. If they respond yes, ask if they take these medications daily. If they respond yes to that question, ask them if they've taken any of their medications today. Then you can move on to P, or past medical history. So this is more pertinent past medical history to the chief complaint. So just ask your patient, do you have any medical history? You can also give them some options that are maybe related to their chief complaint, like hypertension, maybe any history of heart attacks, surgeries, things like that. Then you can move on to L, last oral intake. Here you want to ask your patient, what was the last thing they ate, the last thing they drank, and when was the last time they ate and drank. Then you can move on to E. Here we'll ask our patient, what were they doing when their chief complaint started. Now that we've completed our history taking, I'm going to move on to my physical assessment, or inspect, palpate, auscultate. First, I'm going to begin by inspecting. So I'm going to ask my patient if it's okay if I lift up their shirt so I can take a look at their chest. Once I get permission to do so, I'm going to lift my patient's shirt, and I'm going to look at their chest, looking for any scarring, accessory muscle use, implanted devices, maybe some diaphoresis. And I'm also going to inspect the neck and the legs, inspecting the neck for any JVB and the legs for any edema. The reason why we do this is because those are signs and symptoms of right-sided heart failure. Now I'm going to move into P, or palpation. So here I'm trying to rule out if this is maybe related to a muscle issue or muscle pain. So the patient won't report a change in pain on palpation if the issue is internal. So to palpate, I'm going to have my patient sit up, place my hand on the posterior chest and the anterior chest, squeeze in, and ask my patient, does this change your pain at all? Then I'm going to do the same thing, but on the sides, pressing in on the sides, asking my patient, does this change your pain at all? Now I'll move on to auscultation. So there's 6 fields we want to auscultate, 4 anterior fields, 2 posterior fields. Starting with the anterior fields, we're going to auscultate the 2nd or 3rd intercostal space at the midclavicular line bilaterally, the 4th or 5th intercostal space at the mid-axillary line bilaterally, and then the 2 posterior fields, we're going to auscultate the inferior angle of the scapula, again, bilaterally. There is a chance that you might hear crackles, and this would be indicative of left-sided heart failure. Next, we'll move on to vital signs. So I'm going to get my blood pressure, my pulse, my respiratory rate and quality, my SpO2, skins, and pupils. Your proctor will give you a vital signs card once you list all your vitals. Now that we've completed our secondary assessment, we can go on to our field impression. Based on the findings in our secondary assessment, I believe that this patient's experiencing chest pain of suspected cardiac origin. So we're going to move into our interventions and use County of San Diego Protocol S126 to treat this patient. Per this protocol, you can assist in the administration of your patient's own prescribed aspirin and nitroglycerin. We're going to begin with nitroglycerin as it needs some time to work. There are a few contraindications you need to be aware of before you go ahead and administer nitroglycerin to your patient. There are 2 vital sign contraindications and 2 medication contraindications. For the vital signs, the heart rate must be between 50 and 100 beats per minute. The systolic blood pressure also must be greater than 100 in the County of San Diego and greater than 90 for National Registry. In regards to medication, the patient cannot be taking any erectile dysfunction or sexual enhancement medications within the last 48 hours. The patient can also not be prescribed or taking any pulmonary hypertension medications. Now we can move on to our 5 rights. So here we want to check that we have the right patient, the right medication, the right dose, the right route, and the right time, or making sure it's not expired. We're going to want to double check this with our partner and then triple check all these 5 rights again before we administer a medication to our patient. Next, we can move on to aspirin. There are no contraindications to aspirin, so we can go straight into our 5 rights, again, making sure we have the right patient, right medication, right dose, right route, and right time or expiration. We're going to, again, double check this with our partner and then triple check this before we administer the medication. Now we can move into our reassessment. So we are going to reassess this patient every 5 minutes because this patient is an unstable patient. We would want to reassess things that we assessed in the primary, such as level of consciousness, GCS, ABCs. We'd also want to reassess our patient's vitals and get an updated pain scale. So again, asking them that question on a scale from 1 to 10, 1 being no pain at all, 10 being the worst you've ever experienced, what would you rate it? Then you can move into your turnover. Your turnover is essentially a summary of the call and the patient chief complaint that you provide to the receiving provider. You would want to include things like age, sex, chief complaint, history of chief complaint, treatment, and of course, your patient's response to your treatment.